It's so good to be with everyone tonight. I've already heard through the grapevine that we have a huge audience from around the tri-state area and several people actually from some southern states and Midwestern states. So it's really exciting to be here tonight. I think I'm even more excited because of the outreach and the popularity that this virtual-based program has gained since its inception in July of this year. We've gone from talking about integrative medical modalities and breast cancer, nutrition, obesity, soy products, to empowerment and the psychosocial dilemma. We've gone to breast imaging and what's right for who and when. And I have to say that I'm really, really, really excited tonight with my counterpart. Wave hello. All right, Dr. Arsyl de Jesus, who you see every month on this program, Radiation Oncology at NYOH, to welcome Dr. Elizabeth Poynor, who I've known now, it's scary to say, probably 2 decades, although I look at, and she still looks like she's 20, who is a gynecologic oncologist, as well as an advanced pelvic surgeon with a deep understanding of women's health. And, I looked at her new website that just came out. I've known Dr. Poynor from my days at Memorial Sloan Kettering Cancer Center, where she was the one that I always called, always reached out to, depending on what really tough situation one of my patients was in, whether it was an ovarian cancer, an endometrial cancer, or some, really rare type of presentation. And she was there for over a decade and really was integrating so much by way of wellness and understanding and compassion, and took all of that into a private setting associating with NYU Langone and with Lenox Hill, the first GYN oncologist at Lenox Hill, and actually moved on to a private practice that is called Poynor Health, Wellness, and with Intent. I just love that. And in looking at her website, I think we could take every one of the things that she's involved with and have a conversation about it tonight. Welcome, Liz. Thank you so much for being part of this tonight, truly.
Thank you so much for allowing me to be present tonight. It's so important. And like I said, thank you.
Well, you've been, except for the COVID year in 2020, you've been part of my survivorship programs and my educational programs and seminars, always at the forefront, always doing it pro bono at your own expense of time. And you've been just so incredibly generous. But what I'm going to do is to jump in, because I already have a bunch of questions from my patients that knew that you were going to be coming on today. And I thought we could organize it by going down your website, actually. I'd like to ask you about the first thing that pops up, which is the philosophy of your practice and the philosophy of how you care for women.
So I think that we have to treat the woman as a whole, right? When it comes to treating malignancies, we need to diagnose and treat the malignancy, but we really need to treat the patient. So we look at our foundations of wellness and health, and they require not only identification of illness and treatment of illness, but also looking at those other foundations in terms of other foundations of wellness, which will help any individual move through any health crisis or any health issue, including nutrition, sleep, lifestyle, and terms of relationships and stress management, and how do we put that all together to treat the woman actually, and not just her problem at hand? Because by treating the entire patient, we'll be able to more effectively, I think, manage and help with the problems at hand. So we really focus on that with our patients who are diagnosed with a malignancy or a health problem or serious health problem, but also prevention of other illness and risk stratification, identification, just to maintain optimal wellness, or what we call wellness with intent.
It's so not only well said, but well listened to, because by, looking at a patient in a comprehensive manner, you allow them to look towards a future where often they're paralyzed within the label of their diagnosis or the situation they're in at a very specific time. And I think letting a patient know that there is a future and how to really move forward in that future and giving them the tools that they need is just so important, so important. I'd like to ask you, first up, the question that everybody asks, especially when they've been diagnosed with breast cancer, have survived a breast cancer, or maybe ongoing with treatment for early and also late stage breast cancer. We forget that the patient, when they're outside of our clinical setting, have a life, have a significant other, a friend, children, family, themselves, their own sense of who they are in the community, in their home, their own sexuality. Women, when we talk to them, often come down to one thing. It's the sexuality portion that often is brought to the table up front. And how do they deal with sometimes early castration with some of the medications that we use, and women go into chemical menopause. And you and I have talked about this so much. Women that are on estrogen blocking medications for estrogen positive breast cancer, or have gone into their menopause in their 30s or 40s. And I have patients even in their 70s and 80s who find the urethral burning and the UTIs and the vaginal dryness to be so problematic. The question is always, what can we do about estrogens in that situation?
So we're at a time now where we have some new modalities to help with sexual health, actually, after estrogen deprivation, which is a huge problem. And I think that for many years, it was trivialized a little bit. You know, you need to do this to survive your cancer. So now we look beyond that. We look to surviving and thriving, right? And that term comes from another group, I think, but it really resonates. You want to thrive, you want to live your life actually during and after treatment, right? So now we have many other modalities in terms of helping to maintain sexual health and sexuality. And what I try to impart to people is, look, we may not get it right the first time. We may recommend something, and I'll go through these if you want me to, hyaluronic acid, or we may talk about a laser. We may talk about something as simple as coconut oil or low dose estrogen to the vagina. But to let people know, I think it's important that we're in this with you in terms of getting a solution to your problem and to be outcomes driven. So we want to get you a good outcome, and we'll stick with you as long as it takes. And I think it's important to impart to the women that we take care of, especially with something as tricky as this sometimes, that we might not get it right the first time. And it's a little bit of trial and error. So don't get disappointed, and to move forward and to be supportive and to constantly look for solutions to problems as they arise, because it may be one issue at one time point and another issue may arise, because remember, the human body is dynamic, right? It changes and it doesn't always stay the same. So there are many different ways to approach menopausal issues, vaginal health issues, as we move through either selective estrogen receptor modulator treatment or SERM treatment with tamoxifen or AI treatment, or just simply removal of the ovaries or Lupron treatment. So there's a number of modalities that we can currently pull from that are non-hormonal or low dose hormonal, which some individuals, and you and I were talking about this, may be a candidate for. And it's important that women to realize that, with some of our low dose topical hormones, that they actually are a candidate for them, and to really have that discussion with their oncologist. But I think the most important thing to realize is these issues can be complex. They range from psychologic to physiologic, right? But to find somebody, I think, who's a partner with you in this, in terms of a healthcare provider, whether it's a physician, a PA, or an MP, somebody to help you guide you through this, and also who looks to outcomes, because you want to get a good outcome, and it's possible. I always tell people who may be discouraged a little bit about sexuality and sexual health initially at the beginning, that I've got the benefit of seeing my patients on the other side of this, actually, and I have the benefit of saying, look, we're going to help you through this. So very big talking in big broad strokes. And if you have specific questions, let me know.
Oh, I'm going to start right now. That was exactly the lead in that I wanted, at least for the first, few minutes of this discussion, because we have so many topics to go over. So if we're talking about women who are going to use non-estrogenic products, I always say to my women, how are you using lubricants? How are you using moisturizers? Do you know the difference between the two when it comes to vaginal health? And they'll tell me that they struggle with it the night that they're going to have intimacy, and then I'll say, well, are you using a moisturizer on your face only when you go to a wedding party, or do you use it every day? And they'll say, well, every day. I say, well, guess what? So with that, I'm going to lead it back to you.
So that's really important, right? That this requires maintenance, right? It's not only treatment but maintenance, and it's important. So for example, for non-estrogenic treatments of the vulva and vagina, we have hyaluronic acid, which we're lucky now we have. It's the hyaluronic acid is a naturally occurring compound. It traps waters in tissues, therefore it's a moisturizer actually. And it actually helps to trap water into the vaginal mucosa so that those membranes can be a little bit healthier, actually. And we have hyaluronic acid all throughout our bodies. It's in our joints. It's what helps our joints to be lubricated. And we're lucky now that we have a variety of compounds of hyaluronic acid that you can even buy online or buy in the drugstore. Halogen is one that you can buy. Reverie is another one that you can buy online. It's in the form of a suppository. There are some compounding pharmacies who make hyaluronic acid combined with vitamin E and aloe vera gel, which is also very nice. So there's a variety of hyaluronic acids which are now available. And again, don't get discouraged if one doesn't work for you, because some of them may have preservatives that you react to, or maybe don't have enough of the compound. So we always counsel our patients that, let us know if you're stalling out with this, because there's different ways that we can apply hyaluronic acid. So non-estrogenic treatment. Something as simple actually as coconut oil is a good one. It's a nice antibacterial, antifungal, and it can work really well in terms of vaginal health. Almond oil is another one that we use. Coconut oil, almond oil might be really nice for the vulva and the vagina. So looking at those natural oils. And there's actually some nice natural compounds now that are on the market that you can buy, which are just oils topically for the vulva and the vagina. Sometimes we run into pH problems actually when you apply topical oils. So you have to be very careful, because remember, the vaginal pH is acidic. And that's really important also. And that's an area that we talk about in our practice, because a lot of treatments for vulvovaginal atrophy don't actually approach one of the problems. One of the major problems is the microbiome can be off. So there's billions of organisms that live throughout our body, on our skin, in our intestine, and in our vagina too. So that when the vaginal pH goes up, when there's lack of estrogen, so pH is low with estrogen or acidic, pH goes up with lack of estrogen, microbiome goes off. So in our practice, we also pay attention to the vaginal microbiome. So we'll talk about using some different ways to balance the pH of the vagina, maybe super low dose boric acid, or a vaginal probiotic may be beneficial. Actually not well studied yet, but we're having success with it in our practice. So that's another area to focus and look at. We also look at pelvic floor musculature. So we deal a lot with something in our practice called pelvic floor dysfunction, when the muscles of the pelvic floor get a little tight. And these are the levators and the muscles that support the bladder, the vagina, and the rectum. And so ways that we approach pelvic floor health, in addition to treatment of vaginal atrophy, are actually through pelvic floor PT, which can help to relax those muscles and can also bring in blood flow into the vulva and the vagina. And also through suppositories, which may help to relax that pelvic floor musculature. There's also the CO2 laser that we use now, which is a non-estrogenic mechanical way that we can help with vaginal and vulvar health. Not super well studied in women who have a history of breast cancer who are on AIs and tamoxifen, but there are some studies looking at it that show that it may be beneficial. A little controversial right now, because there's some studies that are coming out now that show that sham operations are actually the same, meaning you treat one woman with a laser and one woman with a sham laser, and they both do better. So there's some maybe placebo effect to it also. And so that's, to be studied, I think, and commented on a little bit further in the future. But there are a variety of ways to approach vulvar vaginal atrophy and vaginal health, which don't rely on estrogenic compounds.
Dr. Poynor, just for practical reasons, is there any prescription form of the hyaluronic acid that we can prescribe to our patients, or do we just direct them online to the, to the resources that you mentioned? And another question that's kind of associated is what kind of coconut or almond oil, just through the baking aisle and get that? So those were the two questions that came up.
Love it. So the hyaluronic acid, right, you can buy online through, Halogen or Reverie, right? There's some other hyaluronic acid compounds that are coming on the market right now. There are compounding pharmacies who actually, and these come from, pharmacies who make medications on custom medications, right? And they do hyaluronic acid with a variety. And you can do, the nice thing about a compounding pharmacy is you can adjust the percentage of hyaluronic acid. You can use other compounds with the hyaluronic acid like vitamin E or aloe vera. But right now, there's not an FDA approved hyaluronic acid currently that I'm aware of. I mean, that changes on a daily basis that I'm aware of. But Reverie and Halogen are certainly two that you can order. And then if you have a more creative individual, they may want to compound the hyaluronic acid for you. In terms of coconut oil and almond oil, there's also a variety of oils now on the market right now so that you don't have to go down the baking aisle. I prefer organic, right? Because there's no chemical extraction of the oils. So I'll direct my patients to where I buy organic oils usually. And so but you can just try to make sure it's organic and not chemically extracted.
Right. The only thing that I'm going to add is, and this is to the audience at large, make sure that you've been seen by your gynecologist, that you've been seen by whoever your physician is that routinely does your vaginal pap smear, to make sure there's no other etiology going on for your discomfort and so on. But it's not just for sexual avidity and health, even genitourinary issues can be helped by all of these maneuvers that Dr. Poynor is talking about, because that mucosa of the urethra is the same mucosa as the vaginal mucosa. So you want to keep that healthy too. I have women who do not have a partner, who are middle-aged, who have recurrent UTIs and are so uncomfortable, and finally getting them to sit down and really talk openly about something like this is really helpful at any age, at any stage. Liz, before I left Memorial, there was a lot of research being done with low-dose vaginal suppositories, low-dose, estrogen suppositories like Vagifem. And one of the things that we were looking at was in postmenopausal women who were being treated with aromatase inhibition. There was a wonderful study that was done in-house and several publications now that have come out where we as medical oncologists would say, no estrogens, you have estrogen positive breast cancer. Now we know that we can potentially treat patients with very, very low systemic penetration of that estrogen. Can you talk a bit about that?
So sure. So originally, Vagifem, when it initially came out, was actually a 25 microgram dose of estradiol that was delivered to the vagina. And that was the old Vagifem, right? And then some studies were done that showed that a dose of 10 micrograms was actually enough. And now we have four microgram dosing. But the original studies were done with 25 microgram dosing of Vagifem and showed that there was no increased risk of recurrence actually with breast cancer, women with breast cancer who use these topical compounds. And now we have, it must have been about 8 years ago, even maybe 10 years ago, that Vagifem was ratcheted down from 25 to 10. And now we have Imvexxy, which has a 10 microgram dose, but also has a 4 microgram dose, right? So that there are studies that have shown the safety profile of these compounds, actually. And the other hormonal treatment is actually DHEA. Actually, the vaginal mucosa responds very well to DHEA. And so a woman who's on an aromatase inhibitor can actually use theoretically safely, and there's been some studies that have shown this, that there's not elevated levels of estradiol with topical DHEA. And that's a newer type of medication called Intra-Rosa. And so that I always, I think that medical oncologists always have a different threshold for allowing an individual to use, or one of their patients to use these medications. So I always tell my patients that once they have a diagnosis of breast cancer, right, it's the breast medical oncologist who is telling, I want to work within the framework of what they're comfortable with and what they are knowledgeable with. So I will always work with the medical oncologist to make sure that they're okay with, what we're recommending. And if they're not, I tried and I feel like the patient is okay, we go back to the data, we go back to the review, and we have a conversation. And I think that's really important, because I think in medicine now we get so siloed into, here's the gynecologist or the GYN oncologist, here's the medical oncologist, here's the radiation oncologist. We all need to be communicative together as a team. And that's why I love working with you, Maria, because we want to talk to each other to help to decide and help our patients live their best life possible. And so I think it's really that dialogue between physicians or healthcare providers is really important, actually, also.
There's no question we as medical providers continue to learn by these conversations, not only the conversations between the medical providers that are so valuable, but also the conversations that we have with our patients, learning what new problems to address, learning what research we should be looking at, learning what questions we should be asking on their behalf. And that's such a huge issue. And I'll just go back to how you started this conversation. It's really stepwise and being patient and seeing what works and not losing faith and having that trust in the you person that patient is dealing with. We could have a whole hour on this, but I would get beaten by many of my patients if we didn't switch off to some of the issues that breast cancer patients have, that survivors have, that family have of breast cancer survivors, and those are the patients that are diagnosed with genetic mutations that may be deleterious. Mm-hmm. And oftentimes we are recommending risk-reducing surgery, and that surgery may encompass organs of the GYN, mechanistically and aesthetically, and by way how symptoms are looked at. And for a long time, those patients that do have a deleterious BRCA1 or BRCA2 or PALB2, and we talk about a BSO, having a bilateral salpingioophorectomy, taking the ovaries out, fallopian tubes, and knowing the person that's going to take them out is so recommended, at least by the age of 40 if you finished your childbearing. But now we're looking at new strategies, because we're beginning to understand that 90% of ovarian cancers actually evolve from the fallopian tubes. And I remember one of the things you said to me about 15 years ago. I had sent a patient to you who had an inadequate oophorectomy. Remnants of the fallopian tube were left behind, and she came, and I was referring her to you because she didn't get into trouble with an ovarian cancer. And you said to me, always tell your patients that they are aware of who's doing that surgery. They have to know how, far to go to remove that fallopian tube. Yeah. Please talk to that, and what some of the new studies at some of our tertiary institutions that you're involved with are looking at.
Yeah, so we now realize that much of ovarian cancer actually comes from the fallopian tube, right? And that it's usually towards that fimbriated end of the fallopian tube, and especially individuals who may have a genetic risk for ovarian cancer, at least with BRCA1 and BRCA2, that much of this may be actually fallopian tube cancer. So we're beginning to have conversations, and this is where you really need to converse with a woman prior to just removing the ovaries and the tubes, and to find out what her fertility concerns are, what are her future fertility concerns and hopes. And because, now we have egg freezing, we have embryo freezing, we have PCR to look at embryos before they're implanted. We have a lot of great technology now that we can use to help women plan their fertility. So it's not always now just identification of a genetic risk and move to prophylactic surgery. It's the question of what do you need to do before that prophylactic surgery, and what should that prophylactic surgery be, actually. So we're now moving into an era where for younger women, we may say, go, and this is all, it's always hard for me to look at, it's not a guideline, but look at a treatment plan. A treatment plan for a woman should be based on her individual family history, her personal history, and her fertility hopes and concerns, right? And so it's important to review, like I said, what are your future fertility concerns? Do you want to do egg freezing beforehand? Do you want to do embryo freezing? Would you like to have a conversation about taking out the fallopian tubes, right? And leaving the ovaries in place for some hormonal function or fertility function in the future? And these studies are ongoing right now in terms of the efficacy of just removing the fallopian tubes versus removing the ovaries and the fallopian tubes. But I think it's super important to have to sit down and to speak with the woman, and to offer her to speak with her about what her various options are, and to also though understand that you can actually remove the tubes and ovaries and have a pregnancy after that, and to carry a pregnancy after that. So we try to have those conversations also. Bilateral self-injectomy, there's been studies that have shown that quality of life is better with just removing the fallopian tubes and leaving the ovaries in for a period of time for very young individuals in terms of menopause and sexual health and sexual functioning. In terms of menopause side effects, there was a study that came out that compared removal of fallopian tubes versus removal of tubes and ovaries with hormone replacement therapy for an individual who can undergo hormone replacement therapy who doesn't have a diagnosis of breast cancer. And the study did show that removal of the fallopian tubes is better than removal of the ovaries plus hormone replacement therapy. Now, having a strong interest in hormone replacement therapy, I would say that probably means the hormone replacement therapy wasn't done right? Because we have to, again, look at the whole individual, right? It's not just a patch and a pill, right? So, but I think it is important to realize too, that we don't have long-term studies with bilateral self-injectomies alone. There was a recent case report that came out that reported that a woman who had undergone, and this is just a case report, but anecdotally, we have to look at those and show us areas of concerns and weaknesses, who developed an advanced ovarian cancer after just the tubes came out. Now that goes right back into how do you do a bilateral self-injectomy? So I actually think that some of my bilateral self-injectomies are not technically tricky, but I've got to pay attention to a lot of detail because those cancers arise from the fimbriated end of the fallopian tube. So ovary, fimbriated end of the fallopian tube, right? So you don't want to leave like pieces of the fimbria behind, because then you're going to leave, possible deposits of where it can develop cancer. So it's important. I actually do all of my bilateral self-injectomies. I do them with a robot, actually, so I can get that hugely advanced magnification. I can dissect off the fimbria. If I need to take a little piece of ovary at the same time to get the fimbria out adequately, that's not going to harm the ovary, I'll do that. So it's super important that you don't just, that the fallopian tubes just aren't removed. They have to be removed appropriately, because you want to get every piece of tissue that's at risk out, basically. So, I think we'll get more data in the future in terms of the efficacy of bilateral self-injectomy preventing ovarian cancer. I think it should be a discussion that we have with our younger patients who have future fertility concerns. But we will get, I think, more definitive information in the future.
And it's important, I think, for women to have that conversation and know that if they do move forward at a young age with resection of the fallopian tube appropriately, that they could go back later on down the line when they're in their 40s and have the ovaries removed.
Absolutely.
Yeah.
I always tell patients, I can take things out. I can go back, take you to the OR for a laparoscopy, take things out. I can't put them back in again, so it's important that those
you were actually the first robotic GYN oncologist at Lenox Hill.
I love my robot. But But I do, it's interesting in my practice when I see my schedule, if I see a young individual or any individual who's coming in for review of prophylactic surgery, right, as a new patient, that's a really long consultation for me. I mean, that's a huge, that will have a lot of impact on her overall health. I always tell people, it's kind of sad in a way. It's really fast and easy to remove the ovaries. Fallopian tubes, a little more detail in terms of like getting this embryo off. But the long-term life impacts go on, health impacts go on forever. And so it's those talking about those significantly consequential health impact that takes a long, that it deserves a big discussion.
I love the way that as information is coming down the pipeline to all of us as providers and patients, that there's a stepwise progression, and it doesn't have to be all right away, knowing that we may be impacting on bone density, whether it's cognitive health, whether it's just the psychological impact of that feeling of it's done, and now perhaps we can move a little bit more slowly. And really, I think this conversation that I'm having with myself right now is really geared to my patients who have lost a family member from peritoneal cancer or ovarian cancer at a young age. They're now 30, 31. They're terrified. And the idea of their being castrated at such an early age is so hard. But in saying that, I just said the word peritoneal. We do tell our patients, even with a bilateral salpingo oophorectomy, you can still get ovarian cancer. And why would I say such a thing? Why would I even say such a thing? Please run with that.
Right. So there's a risk of primary peritoneal cancer, which is a cancer that acts like ovarian cancer, looks like ovarian cancer under the microscope, but is not. I think we still don't really truly understand where peritoneal cancer arises. Does it arise from embryologic remnants? Does it arise from areas of the peritoneum that have undergone some type of transformation? But it can occur after the ovaries are removed and the fallopian tubes are removed. Originally, when we started doing prophylactic surgery in the late 80s, right, the risk of primary peritoneal cancer after prophylactic surgery was actually 10%. It was high. The number was really high. And that probably was due that we were operating only on with very high risk families. And also there may have been microscopic deposits at the time of surgery, because now we section the ovaries differently. We section the fallopian tubes differently. So we're really looking for microscopic disease at the time of surgery, actually, so that when we remove tubes and ovaries, actually there are strict ASCO directed protocols in how that tissue is looked at underneath the microscope. But with that being said, the numbers now are much less, right? So it's a less than 1% chance of developing primary peritoneal cancer after a BSO. The reason that number is probably lower is we're operating on a larger group of individuals, but we're also sectioning the ovaries. Every once in a while, we'll find an early fallopian tube cancer when we remove the ovaries at the time of prophylactic surgery. So this may have been something that had been missed in the past, and then it's labeled as primary peritoneal cancer, maybe a cell that has escaped at the time of surgery and just wasn't recognized. So, but we do follow our patients in our practice after prophylactic surgery. We don't say goodbye, go back into the community. We still follow our patients pretty closely after surgery, because we want to hear about early symptoms and signs of any type of intra-abdominal process which may be occurring.
What about that young woman who hasn't had her family yet, who is still looking towards her fertility, is engaged to be married in 2 years? What about that young woman who is not ready for any kind of risk-reducing surgery? How do we follow her? How do we screen her if she has a BRCA mutation or a PALB2 mutation, or any of the other mutations that might impact on some, GYN oncologic malignancy?
So there's currently no guidelines, right, set for ovarian cancer, because ovarian cancer
That's
screening.
why I threw that at you.
Yeah. There's currently no accepted guidelines for ovarian cancer screening in this country, and certainly people are looking at different ways and different biologic screening methods for ovarian cancer. But to date, it's been very difficult to prove that that ultrasound imaging of the ovaries, along with a tumor marker called CA125 or AT4, will actually pick up have ovarian cancer at an early stage, which it's curable, because early ovarian cancer is actually curable like any solid tumor, right? So there's a 90% cure rate at a stage 1 with a stage 1 ovarian cancer. But the problem with ovarian cancer is a sneaky one, right? And it usually doesn't present until it's a little bit more advanced, or stage 3 or stage 4, where the tumor is spread throughout the abdomen, and then it becomes very difficult. You still can cure it, but it's very difficult to cure it. I would argue that we're looking at the wrong things. We look for very large changes in the ovaries or the fallopian tubes. And I would argue that in ultrasonography, we have a very large imaging interest in our practice, that we're looking for the wrong things, where we should be looking for the subtle things. The bigger things are everything is has broken out of the gate, so to speak. So we want to look for those very subtle early changes where we can pick up things a little bit early. Is there fluid in the fallopian tube? Is there fluid associated with a solid area in the fallopian tube? And these are things we need to look at. And UK, they've started doing this a little bit. They have what they call expert pelvic ultrasonographers. So many times in this country, if you go to an ultrasound imaging location, you're going to have an ultrasonographer that does carotids, does your heart, maybe does your aorta, does your pelvic, so, but not somebody who just does pelvic ultrasound imaging. So I think that we need to look at this a little bit more closer in ultrasound imaging, in terms of what should we be looking for with early changes of ovarian cancer. We're not looking for large masses. We should be looking for subtle changes in the fallopian tubes, maybe even. So there's no strict guideline. If you look at the NCCN guideline, they say perhaps women would like to have a CA-125 and an ultrasound every 6 months, right? And so, I think that, certainly in our practice, we do quote unquote screen. We look for subtle changes. We're not looking for the big things. We're looking for little solid areas, or little areas that may have hypervascular areas. And this is what we need to, I think, study and look at a little bit more closely. Also, for a younger woman who's considering prophylactic surgery at some point, this is where I think that our great fertility technology really needs to be reviewed and discussed. And I'm happy to see that there's more guidelines coming through, and it's a focus now with ASCO and other organizations, that to really put that up front in a patient's treatment plan, whether she has a diagnosed malignancy or is having prophylactic surgery. We have all these great technologies now that we can use for ovarian stimulation, egg freezing, egg harvesting, and which has become more effective now, embryo freezing for the woman who's in a committed relationship, or wants to freeze embryos with a sperm donor, right? We can do that too. So there's all sorts of different ways to put the story together for somebody, which is, I think, highly individualized.
It makes so much sense. When we're looking at breast imaging, I had Liz Morris on just last month, and we're looking for microcalcifications. We don't want to find the big mass. You want to find the subtle vascular changes. You don't want to find the lymph node,
Right.
which is so there and obvious. And it would certainly make Arsyl's life much easier, because it'll be less radiation that has to be handled. But that for me, hearing this tonight makes me very happy, and hopefully and I'm sure it already has on multiple levels, just hearing about your own practice, but really making me happy that there's continued expertise that has to be developed, that we need, quality assurance, that we need more training, just like when sentinel lymph nodes came into the forefront of the breast cancer arena. Very exciting, very exciting. Do we have questions? Because I see the chat box and the Q&A lighting up.
I think their concern was for those that, one question is for those that do not have a deleterious mutation, but do have breast cancer and have seen a lot of correlation between the two. Is there any role for, doing any kind of additional screening, or, outside of the annual female exam? She pointed out basically that, the woman should be treated as a whole, which I totally agree. What can we look at or advise our patients in terms of wellness, our breast cancer patients, with regards especially to the potential for gynecologic malignancies? Again, no deleterious mutations in this one.
So I think this is a little, again, controversial, right? In terms of when we have an individual who has a breast cancer alone, who doesn't have a family history of any ovarian cancer and has only breast cancer in the family with no deleterious mutations, the risk of ovarian cancer goes back down to a baseline risk, right? Of 1.6% of individuals will develop breast cancer. I think this is where it becomes really important to have these conversations about, would you like to have your ovaries looked at? It is not standard of care. It is not a guideline to do that, but it is a conversation you should have with your healthcare provider about what are the risk benefits and alternatives. It also becomes where you really need to listen to your body. What are the early warning signs and symptoms of ovarian cancer? You know, we've thought many times that ovarian cancer has no symptoms, but Deborah Goff and her colleagues out west in Washington State showed that ovarian cancer does have some early signs and symptoms. They're extremely subtle. Many individuals may have them, but they should always be evaluated when they're persistent. That may be fatigue, urinary frequency, back pain, pelvic pain. Of course, abnormal bleeding should always be evaluated. So I think you have to listen to your body. I think you have to have these conversations with your healthcare provider in terms of what type of imaging or screening that you would look at. But really, the other group that's really important, though, is that group that may have ovarian cancer in the family that doesn't have identifiable mutation. Because remember, we look for 85 cancer predisposition genes when we do large panel testing, but there are probably many more that we just aren't aware of. So the tricky family, I think, an individual that may not get always managed appropriately is a woman who has a family history of ovarian cancer, who doesn't have a deleterious mutation. It doesn't take you off the hook that there might not be some hereditary component. So again, you always want to look at 3 generations of your family history. You really want to talk to people in your family, and you want to have those conversations with a knowledgeable, either your medical oncologist or a geneticist or clinical genetics counselor, or somebody who's knowledgeable about hereditary patterns of cancer.
You know, and I always emphasize when a patient is coming in for their standard follow-up visit, you know, we take such a comprehensive history and physical and when we first meet the patient, but you know, as we see them 2 years down the line, 4 years down the line, 7, is there a new diagnosis in the family? Never forgetting to ask that. Is there anyone new this past year that's been diagnosed with either a pancreatic cancer or an ovarian cancer or breast cancer? And that falls on us as providers, but needing to educate, you know, our patients that they should be coming in with that information, as well as the families of our patients speaking to their own primary care physicians.
Yeah, that's super important. That interval family history is really important. And also doing what we call update genetics is really important, right? Somebody may say, oh, I had genetic testing. You'll say, like, how long ago was it? Like 13 years ago, you know? And so we like to put in the chart, like, when was your genetic testing? What type of testing did you have? What genes were looked at? And so that's super important also, I think. So to review that always is important, you know, always review that new family, interval family history, or when the last genetics were done, actually, and review update genetics.
Sure. You know, familial history is familial history, and we just haven't discovered genes that are waiting out there for discovering them. So it's a huge, huge issue. You know, I remember, now I'm going to really date myself, going back over 30 years ago, when the only hormonal drug that we used in the adjuvant setting, we weren't even talking about chemoprevention back then, was tamoxifen, you know, which is a serum. And back then, the whole issue of the potential for uterine cancer as a secondary malignancy from the treatment with tamoxifen was so big. And I remember Rich Barakat and that whole group, you know, doing pelvic ultrasounds and measuring the lining of the uterus, only to down the line realize that, number one, it wasn't that common. Number two, it was usually women who had been on very different hormonal replacement therapy back then. Sorry, that's my Luigi. He must have heard a coyote out there. You know, I'd love for you to speak to the audience about that, because these are still questions that are inherited from different generations and still come to the forefront as one of the fears. And I tell patients it's almost unheard of for a premenopausal patient to develop uterine cancer, because you're shedding your lining, which is a very simplistic way of saying it. But I have to say, other than those rare sarcomas,
Yeah.
Tamoxifen induced, and there have been cases reported with tamoxifen that was presented by the NCI. It's so very rare, and I do not recommend routine ultrasounds for the endometrial lining. I may be wrong. Tell me.
So, well, no, you're right.
Of course I am.
Of course you are.
Of course I am.
The data is that the endometrial cancers, which are uncommon, but although elevated with tamoxifen, because tamoxifen is SERM, so selective estrogen receptor modulator, so proestrogen on the uterus, anti-estrogen for the breast. The risk of uterine cancer is elevated. However, it always presents with abnormal bleeding, right? And it's an early stage cancer when it presents with abnormal bleeding. And so in the past, we were doing biopsies and ultrasounds. So the standard of care is not necessarily to do a ultrasound for an individual who is on tamoxifen. However, it is always important to evaluate any abnormal bleeding which an individual may have. Super important. So super important to always be aware that any postmenopausal bleeding or perimenopausal bleeding that's unusual or different should be evaluated. Or if you are bleeding each month on tamoxifen, and if you have a change in your bleeding pattern, bleeding between your periods or heavy periods, that should definitely be evaluated. I'll sometimes recommend a baseline, actually, ultrasound for younger women who are on tamoxifen, just to make sure that there's no uterine lining problem moving and starting to take tamoxifen, just to provide a baseline. And, so that's something that we'll recommend many times. Pelvic imaging for women has always been very extremely controversial, right? The benefits in terms of early detection for anything, right, basically have been outweighed by the risk of ultrasound imaging. That was the PLCO trial that was done and published about 6 or 7 years ago that showed when you did imaging for all individuals that the harm of surgery, which was recommended to women because of findings, was actually outweighed the benefit of early detection. Again, I think we have to look about how we recommend surgery and how we interpret abnormal findings, actually, and not to be alarmist about them, because I think some of our problems with imaging are we can get a little alarmist about them and become a little bit overly aggressive surgically, which can actually harm somebody. So first, do no harm. So I think that the role of imaging with women's health is an evolution. I don't think it's static. I think it's an evolution, actually.
And again, there's nothing wrong with a second opinion. If a screening ultrasound or some ultrasound, or for whatever reason, or any imaging is found to be, concerning, know who you're reviewing it with, know who's making the recommendation.
Yeah, and that also comes from the Brits too. They had data that showed that if you had an expert pelvic ultrasonographer, you were less likely to be recommended surgery and more likely to have laparoscopy if you were recommended surgery. So again, it's in women's health, we have GYN oncologist, and then we're siloed, right? We have GYN oncologist, REIs, urogyns, and a generalist, right? So we don't have that. There's almost needs to be a role as women transition through midlife and on of having an individual who is an expert in risk stratification and identification of problems, because we are very separated in how we practice in OBGYN. So that, again, I think this is a topic in evolution.
Dr. Poynor, there was a question that came through. If you could kindly comment on fibroids and endometriosis and any worry about cancer in general, gynecologically.
So fibroids and endo are actually interesting. I'll just back into it with tamoxifen, actually, because we were talking about tamoxifen, because TAM can make endometriosis grow and can make fibroids grow, right? So important that you're aware of that diagnosis before you are treated with tamoxifen, and be aware of that's something that you need to be followed for. Endometriosis is associated with an elevated risk of ovarian cancer. It's associated with an elevated risk typically of endometrioid cancers of the ovary, which are not the typical papillary serous cancers of the ovary. They're usually detected early. They usually kind of sit in the ovary and don't break off early, like those ones that probably arise in the fallopian tube. You can also also develop cancer in areas of an ovarian cancer type like, or endometrial cancer type like, in areas of endometriosis. So important, actually, with endo, we actually follow our patients with endometriosis with interval screening, and of course, careful attention to detail in terms of symptoms.
Thank you.
Any other questions, Arsyl?
No, I mean, there was one about your thoughts on liquid biopsy and when that should be done, but I didn't really think how connected that is to what we're discussing at this point.
Okay. That's something that we can address after the San Antonio Breast Cancer
Exactly.
Symposium, where that is going to be presented, and we'll have new data on that. What about when do you start talking to your patients about genetic screening? I've heard you give an hour lecture, and it's always been so comprehensive and so really commonsensical to listen to regarding just overall genetic screening, and what are the alarms that should be going off other than the family history, and what in the family history, and what kind of screening should patients have. And oftentimes patients will come into my clinic and they say, well, my insurance wouldn't cover XYZ, so I got the mini panel done, and then I'm sending them back. So let's talk a little bit about that, because we're always dealing with that on a daily basis. Genetic screening, what does it mean? What are just some highlights? And I know there's no way to do this in 4.5 or 5 minutes, but whatever you can give us.
So I think, we have very young patients, so I take care of daughters and of patients in my practice, right? And in some I have 4 generations in one family, which is pretty cool, I think. But so we have a lot of, we really want every patient who comes into the office, no matter how old they are, to understand their family history, right? Because for a younger woman, we'll, go over self-breast examination, and not to be alarmist, but to be aware, information, knowledge is power, right? And so we want to empower the patients women that we take care of with information that they bring to us, right? And how that may impact their personal health history. So when to consider genetic screening and testing, I have that conversation in terms of family history in a non-alarmist fashion with all my patients. They may be 15 or 16 years old, but just to be aware this is your family history, and these are things that you can do to be proactive with your family history, but not to be scared or worried about. Generally the guideline is, if you have a BRCA1 or 2 mutation or a deleterious mutation in a cancer predisposition gene, is to consider testing by the age of 25, right? Because we will initiate breast cancer screening, right, for our 25-year-olds and on. So that generally by the age of 22 to 25, we'll say, look, if you have a family history of BRCA1 or BRCA2 mutation, this is the time to begin to really think about it. That being said, younger people are of the information age. Like my son is 19, he's a big data person. He doesn't make a decision without big data, right? So I find that actually some of my younger patients just want to know everything about their health. They've gone, and the great problem is that people will go out to 23andMe, right? Oh, I've had genetics, I did 23andMe, right? So they're going on 23andMe and they're looking at their risk of all these other issues. And so we if somebody's doing that and somebody's interested, I'll actually have that conversation with them in terms of genetic screening and testing, right? But if younger than the age of 18, usually not, of course. And, but a little bit older than that, in that 22 range, a lot of young women want that information and can deal with it. That being said, I have 30-year-olds who don't want to have their genetics done, right? So I think we're all very different the way we handle our personal health information and how we want to deal with it. And I always think it's really important to work within the framework of how an individual wants to manage their health history, and to educate individuals about how this information would change perhaps their fertility plans or would change their screening, and to have that conversation on a highly individualized basis, right? And then in terms of what type of genetic testing to do or screening to do, everybody came to me when the New York Times article was published about POLB2, right? And I was like, but you had that done 10 years ago, so you can look at these very large panels and do them. And or you can do these very narrowed panels. I like the large panel. I'm a Affymatrix screening person, right? So I think more data is better, right? So I like the large panels. The problem when you do a larger panel for genetics, though, is you make it information that's difficult to interpret and to understand, right? But I don't think that any genetic information is black or white, right? So I think that it all requires interpretation within an individual's personal health history and their family history. So I'm going to punt a little bit and say it's highly individualized and it depends on the maturity of the individual, but we always discuss everything within the context of an individual's personal health history, their family history, and the known or unknown deleterious mutations which may be in their family.
Yeah, there are two comments. I don't think there's a week that goes by, even when I'm on vacation, that a patient who might be in her mid 40s or early 40s who has a 12-year-old or a 13-year-old, when should I bring my daughter in? When should I test my children? I always tell them, wait until they graduate college. You don't want to impact on their view of their own body image or any psychological trauma. And it's an ongoing conversation. But it's such an evolving field, and as we begin to identify more and more genes, more and more variants, we are going to find more deleterious mutations. It's just the beauty of science and almost the hell of science at the same time, because I don't know how quickly we're able to catch up, but we're doing so much better than we did before. There are so many things that I want to ask, and I'm looking at the time and we're getting to the end of this. I told you this was going to go by quickly. And I'm getting text messages on my phone saying, can you have her on every month? So, this has really been amazing, but I'd like to just say to those that do not know their family history, either because they have estranged family members or there's a family history of breast cancer, but it's the dad's sister or the dad's mother, do not lose sight that these genetic mutations can come down the male side of things. And even if the mother's history is perfectly pure and without a cancer diagnosis, we still have to pay attention to both parents' side. And if I have patients who are adopted, I mean, with breast cancer right now, virtually everybody is getting genetic screening. But if I have an adopted patient, someone who's been adopted and doesn't know their biologic, family history, even from 30 years ago, as soon as we got genetic testing done, I would test those patients. So be aware of both sides of the family. I can't tell you how often it's the father and the son and his brother and the grandfather who had breast cancer or pancreatic cancer. And, now we're dealing with the daughter or the granddaughter and what she should be doing. I am going to just say, I am forever grateful. I am. I just love you to death. I wish I could just duplicate you and clone you and have you in every practice everywhere, because you're making it so much easier for women and taking the taboo away from the conversations. We just got a question here. As a 17-year survivor, stage 2B, and then needing GYN surgery a year after due to cancer cells, and then it cut off. Do you have that question, Arsyl, or that comment?
Yes, it says, I wish you all were available way back then. My genetics is all my dad's side. My sister got breast cancer years after I did. So thank you for these sessions. They're very informative for those of us that have graduated and no longer are active. Maria, my take home here is this. I think communication is key. Knowing your family history is key, and having and initiating that conversation with the right people. Like you said, I can see why you adore Liz, because she would be the what will make a difference in a woman's life. And I wish that we did have her or someone like her. So I'm looking forward to, maybe working with someone in our in the Capital District that can be a Dr. Poynor for our patients, so that we indeed can also offer better survivorship for our women, who have gone through breast cancer treatment.
And with all due respect to the providers up in this part of upstate New York and who are associated with New York Oncology, Hematology, everybody is looking forward to being the best expert in their field, having programs like these, like we're having tonight, being amenable to preceptorships in tertiary centers. I suspect a couple of people are going to want to look at your high-level ultrasound practice and see if they could copycat you, but that's what it's all about. I remember there wasn't a week that I practiced at Memorial that I didn't have someone from some part of the world, not just the country, who was following me in my shadow, trying to maybe pick up a pearl. I hope I had them to give, but I'm going to close this session. Arsyl, I'm going to thank you for always being there and saving the session when I have no idea how to start these Zoom calls. Certainly to the people behind the scenes, to Cara Wilkes and to Kelsey Sargood. Thank you for putting this together. And Liz, what can I say? I just love you, love you, love you.
Thank you, Maria. The feeling is mutual. And I just want to thank you so much, because I think that we just have to get the word out for everybody. And thank you so much. And education is the only way to drive the message or to drive care for women forward. So we're certainly working in that direction. So I so appreciate you allowing me to be here this evening. It was a lot of fun.
Thank you to all the attendees. Thank you for promoting this program and being part of it. Let your friends know, let your doctors know, everybody's invited.